this has been a dream, and for the last 2 weeks, it has been realized in different categories and different levels, of which I'm very much thankful for all who participated in making this a possibility. So thank you, guests of honor, for taking your time out of a very busy schedule. And this was like a very short call after the intended guest of honor, the Minister of Health, Honorable Umi Mwalim, apologizing or postponing coming here simply because of other government duties. And so I'm very much thankful for taking your time and coming here to participate into this all-important emergency conference. And so before I begin my speech, allow me to make a brief introduction of everyone who is seated here, and I'll do this in groups. I would like to recognize the presence of people from South Africa. Professor Petra, welcome. From Australia, they are not yet here. We have people from Kenya. I believe we have Janet, we have Professor Ben. Still sleeping somewhere. From Nigeria, Ugu. Okay, I understand we have someone from Namibia, according to the registration. Maybe still finding their way here. From the United States of America, everyone from the US. All right, and I don't know if I've left anyone who is not from this country. So this time for everyone from Tanzania. All right, we have guests of honor from Tanzania. We have representation from Dar es Salaam. I would like to see people from Dar es Salaam waving. People from Morogoro. Participants from Zanzibar. From Lake Zone, we have participants from Mwanza, Shinyanga, Highlands of Tanzania, we have Njombe, and Central Region, we have participants from Dodoma and Singida. Southern Tanzania, we have representation from Lindi, Ruvuma. Western Tanzania, Tabora, Kigoma, Katavi. And northern Tanzania, we have Kilimanjaro, Manyara, and the host Arusha. They are still sleeping. If you're from Arusha, can you wave, please? Don't let me down. Okay, so importantly, guests of honor, allow me to introduce officially Ambassador Daniel Olenjolai, who recently became the chairperson for the Same Qualities Foundation Board. And I'm really honored. Ambassador Olenjolai served in this country in different levels, being a regional commissioner here in Arusha, regional commissioner in Mwanza, and was an ambassador for Tanzania in Nigeria. So Ugu, she will touch base with the ambassador, Ambassador Njolai. 10 years ago, SQF was founded and registered officially by the Minister of Health in October 2014, whereas as an organization, it started executing its main objectives as follows. 1, we started supporting and helping children born with the congenital abnormalities, of which to date we have operated children with cleft surgeries. Over 1,000 children of this, with this program have been operated across the country. And this includes 14 regions covered in Tanzania mainland and Zanzibar Island. As a socially responsible organization, SQF decided to bring these services closer to the community, and this is because most of them could not afford the cost of travel and accommodation or living to centers where these services are provided. And so we forged Is emergency care in Tanzania. Since its establishment as a specialty in 2010 at Muhimbili National Hospital, emergency care has evolved a lot, and we have witnessed a substantial reduction in mortality across the country in hospitals where emergency care services are available, and we really commend you and the government for establishing hundreds of emergency departments across the country in the last 2 years or so. To complement this, SQF has been providing training to healthcare workers on emergency care at different capacities and levels, of which over 1,000 healthcare workers have been trained in different emergency care courses. 5 years ago, in collaboration with the COPI is an American-based NGO, and I suppose Nathan is here with us. He's running another track of emergency care, trauma care in one of the breakout rooms over here. He'll be here shortly presenting this afternoon. So we started training traffic police on trauma care. This has taken us 5 years to date. And this is because as a country, we don't have a formalized emergency medical services. So we decided to train the traffic police simply because these are the ones who are always deployed whenever an accident happens. These officers lack emergency care training, and in this regard, SQF decided to empower them with the basic skills and knowledge. And to date, we have trained at least 481 police officers on emergency care and mental health. Nevertheless, at least 50 healthcare workers have been trained on ambulance emergency care, like how to treat and handle patients while they are traveling between facilities or from they come into hospital. And this year alone, we have run a trauma care and mental health training to 48 police officers from the traffic and criminal investigation departments and 8 pastors and evangelists from the western region of Tanzania, Kagera, specifically Karagwe district. We also thank our friends from the University of Minnesota, Hennepin County Medical Center, Emory University, Mayo Clinic, University of California, San Francisco, our friends from Australia who have been supporting us for years in training of our healthcare workers here in Tanzania. And representative from these institutions, please, if you are in this room, can you wave? From those institutions, yeah. Thank you so much. Can we clap for them, please? This year, SQF decided to make some improvement on the emergency symposium we used to conduct here before COVID came into existence. We decided to involve more diverse healthcare providers, conduct needful workshops, and invite well-renowned speakers and instructors from across the world. This gives us and the government an assurance that our healthcare workers get what is necessary to save the lives of those who need emergency care most. The theme, Empowering Healthcare Workers, is in line with what has been done in the past 2 weeks, in which 9 pre-conference workshops have been conducted to over 221 participants. We have been running BLS plus PALS to 29 participants, BLS plus SLS to 43 participants, emergency ultrasound and echo to 21 participants, clinical research, we had 70 participants, critical care to 14 participants, pediatric emergency to 10 participants, mental health to 60 participants, and trauma care for the police, 56 participants. A total of 35 scientific presentations on cardiology, trauma, pediatric emergencies, critical care, clinical research, career development, and several scientific abstracts will be presented in the next 2 days from today. At least 50 speakers from the US, South Africa, Australia, Kenya, Nigeria, and Tanzania have laid down their work and are expected to be to actively engage in discussion with other participants during the conference and breakout sessions in the next 2 days. Lastly, but not least, I would like to thank all stakeholders, partners, collaborators, including but not limited to the government of Tanzania through its Ministry of Health, President's Office, Region, Administration, and Local Government, the Minister of Home Affairs, Smile Train, MCure, BSV Pharmaceuticals, CSSC, COPI USA, University of Minnesota, Hennepin County Medical Center, Blink Internet Arusha, and all other stakeholders who have been supporting us in different capacities to make this conference a reality. I also like to take this opportunity to thank the organizing committee. I hope they are here with us. Can you please stand up? Members of the organizing committee, we did this virtually, like everyone in his from his or her own place, and here we are. So thank you so much for doing such a wonderful work. In the future, guests of honor, we would like to make these conferences even more robust so they can be more engaging. We have started the groundwork for the next conference in January 2025 so that we can have even more workshops to train our local healthcare workers. We also ask the government to allow them whenever a conference like this happens so they can come and participate and gain more knowledge and skills to go and impact emergency care wherever they work. With that, guests of honor, as I finish my speech, allow me to welcome Dr. Simbila, who is representing Emergency Medicine Association of Tanzania, for a few remarks, and then he will invite you on stage to give your speech. Thank you, everyone.
Guest of honor, allow me to stand on the established protocol. Dear colleagues, ladies and gentlemen, don't be surprised because I have many hats. I am the organizer, I am an EM physician, I am the presenter, and now I am the representative of the president of the Emergency Medicine Association of Tanzania, Dr. Juma Mfinanga. I work as an EM physician with the Muhimbili National Hospital. I am also an honorary lecturer with the Muhimbili National University of Health and Allied Sciences, but I'm also a member of EMAT. And for those who do not know, EMAT is a non-profit organization or association of EM care or EM care providers all over Tanzania. And its members include all healthcare professionals and providers from all cadres: nurses, EMTs, doctors, assistants, clinicians, lecturers, researchers can all be part of the Emergency Medicine Association of Tanzania. So you may be wondering what Emergency Medicine Association of Tanzania does. Its main role is to pioneer EM care in Tanzania in terms of training, developing systems, establishing facilities, but also doing sustainability plans in terms of teaching, developing teaching material, and mentorship. So it works in collaboration with institutions, both national and international. To name a few, the Muhimbili National University or Muhimbili University of Health and Allied Sciences, in which it supports training in supporting the residence program in various aspects. It also works in collaboration with the Abbott Fund, who are the main funders of the association. It works with both the government entities and institutions, for example, the Ministry of Health, the President's Office, regional administration, and local government, through which it has enrolled programs of teaching in areas of critical care and emergency care. It has many chapters in Tanzania in different regions, including Arusha, where we are now, the nearby Kilimanjaro, the southern islands, including Mbeya and Iringa, the Pwani region, and Dar es Salaam, where it was first found. So we congratulate the organizing committee of the Arusha EM Care or EM Conference, and we invite them to be part of the Tanzania Conference of Emergency Medicine, TASEM, which is usually held 2 yearly. We also invite all people, all healthcare providers in EM care and emergency care who would wish to be members. The membership is open for all, so welcome. And on this remark, I would like to invite all of you to learn, be part of this conference, enjoy it, enjoy Arusha after the conference, and thank you very much.
Thank you so much, Dr. Peter Mabula and Dr. Alphonse Simbila, for the talks that you've just given a few minutes ago. Moving forward, I would like to welcome Dr. Omar S. Chande. Dr. Omar S. Chande is a representative from the Regional Medical Officer's office. He is an ENT. And today he represents the Ministry of Health, Dr. Umi Mwalimu, who was supposed to be our guest of honor. Warmly welcome to Dr. Chande.
Honorable Ambassador, Director for Same Quality Foundation, instructors who are here, speakers, participants, invited guests, ladies and gentlemen. And again, President of EMAT, who was recently here, organizing committee. Good morning, everybody. Jamhuri ya Muungano Tanzania. Yeah, as I was introduced here, I'm from the Regional Medical Officer's Office. I'm carrying the oral health profession myself, and lucky enough today I'm supposed to represent the Minister for Health, Mama Umi Mwalimu, who was supposed to be our guest of honor today, but very unfortunate, she has to attend another matters. in the country, then we take the responsibility after that happened. So, but before I go to embark on her speech, let me now take the responsibility of the region. Arusha, I understand most of you have traveled from far outside the country, some outside the region. Then therefore, I have to take this moment to welcome you all to Arusha. Maybe most of you have not been here before, but you got this chance to be here. Then you have to utilize the important places in Arusha as the touristic center in the country. So use this moment to at least to attend all those areas which you feel you can visit. Arusha itself, as you have seen the atmosphere here, it is, I don't know, I can say it is not very cold, but it is cold for some of you who come from tropical places like Dar es Salaam, Tanga, and so forth. So you all feel at home, feel free to move around, and I can assure you people here are very friendly, and you may stay here very peacefully until you finish the mission you have come for. Now allow me to move to the minister's speech, and I can say, you know, if you are supposed to represent the speech of the minister, then you have to read it as it is without putting more words from your side. I'm starting by nawasalimu kwa jina la Jamhuri ya Muungano wa Tanzania. Yeah, I'm very pleased to be here today to officially open this important emergency medicine conference as SQF celebrates its 10 years of service. It is now 10 years since the Same Quality Foundation was founded and officially registered in October 2014, with the main objectives of supporting and helping children born with congenital abnormalities and spreading emergency care in Tanzania. And we are pleased for the decision taken by SQF. I hope you all know SQF is Same Quality Foundation organization to bring these services closer to the pleased, to the born with congenital abnormalities, to bring these services closer to the community, because most of them could not, and still many of them cannot afford the cost to travel to centers where such specialization services are available. At the Minister of Health, we are happy that during this period, over 1,000 free cleft surgeries have been done across the country. Through establishment of medical camps, in different hospitals which are your partners. On behalf of the government of Tanzania, we appreciate the generous partnership you have had with these hospitals, including, let me name them, TPC Moshi, NSK Arusha, Haydom Hospital Banyara, Kahama District Hospital, Ndolaga Hospital Kagera, SDA Pasiansi Mwanza, Singida Royal Referral Hospital, Bunda DDH, Mara, Nazi Moja Zanzibar, Kivunge Hospital Zanzibar, Abdallah Mzee Hospital Pemba, Dodoma Regional Referral Hospital, Malolo Hospital Tabora, Mbeya Zonal Referral Hospital, Simiu Regional Referral Hospital. It is also great to hear that SQF is supporting the government initiatives to strengthen rehabilitation and emergency care services in the country. I congratulate you to establishing malnutrition rehabilitation for children with clefts in Dodoma and Zanzibar, both serving as centers accessible to many Tanzanians. Rehabilitation services are part of my priorities this year. With regards to emergency care, the government of Tanzania, through the leadership of Her Excellency Dr. Samia Suluhu Hassan, has invested a lot in the healthcare, including establishment of emergency medicine department for the past 2 years. We have established and equipped 82 new EMDs in district councils and in all 29 regional referral hospitals in all 26 regions in Tanzania. 7 EMDs in all zonal hospital, 2 EMD in specialized hospital, and we have also renovated and established EMD. The government, through its Ministry of Health, is hereby appreciating what CQF has been doing in a course of 10 years, and we promise that we will support SQF for all what it does. This conference is expected to empower healthcare workers with knowledge and skills which will add value to the emergency care services across Tanzania and beyond. I'm calling for all medical professionals to continue working hard and uphold the medical values to improve outcome of patients with emergency conditions. I also call upon all healthcare workers to work together to strengthen emergency referrals using well-equipped ambulances and well-trained healthcare workers. With these few remarks, may I now officially declare that this conference is officially open, and I wish you all the success and enjoy the beauty of Arusha and Tanzania in general. Thank you very much for your listening.
Thank you so much, Dr. Omar Chande. With that said, I would like to sincerely welcome Ambassador Daniel Ole Njiloi, who is the chairman of the board of Same Qualities Foundation. Karibu.
Morning. My name is Daniel Ole Njiloi, as I have been introduced before, and I'm the new chairman of the Same Quality Foundation. I think I have hardly a week being a chairman, so I still need to learn more about the Same Quality Foundation. Dr. Mabula and his group, I think, approached me and requested me to be chairman. And because I know him very well, because I worked with him in my other capacity as chairman of the Arusha Lutheran Medical Center where he was working before. So I know him very well. I failed to let him down. So I accepted wholeheartedly. I think I'm going to learn more, and we are going to do a wonderful job. Let me take this opportunity, as you have been told. I was formerly the Arusha Regional Commissioner, so I know Arusha very well. So let me take this opportunity to add to what the representative of the minister said. Arusha is a nice place, Arusha region. There are quite a number of nice places to visit. The closest is in Arusha National Park, which is hardly 45 minutes drive from here. Then there is Tarangire, which is about an hour's drive from here. Tarangire National Park, you'll be able to see so many elephants. And there is Manyara National Park, which is also about an hour or so drive from here, an hour and a half maybe. There is Ngorongoro, which is about 2 hours drive from here. So Arusha is full of so many places to visit. Please don't go back to your places, to your homes, without visiting one of these places. You won't regret, I can assure you. And the roads are passable. All roads to those places are tarmac roads, so please take time to enjoy the beauties of Arusha. Having said that, let me take this opportunity to say thank you so much. Thank you so much, Dr. Chande, for representing the Minister for Health. This is a good omen. You might become Minister for Health sometime. Who knows? Thank you for the remarks from the Minister, and especially for her commitment to work together closely with the SQF. We have noted that very, very clearly. We are not going to let her down as well. We'll make sure that everything goes as per our plans. So kindly reassure the Minister that SQF will continue working very, very closely with the Minister of Health to enhance the well-being of children with congenital problems in Tanzania. I think as a vote of thanks, I think that is enough, because you guys have a lot of time, you need a lot of time to go into groups and discussion groups on professional issues that are supposed to be discussed on emergency medicine positions in Tanzania and other parts of the world. I thank you very much.
Thank you so much, Ambassador. So before I welcome the three keynote, Professor Ben, Professor Petra, and Erasto up here to sit with the high table getting ready for their keynotes, I would like to give a small gift to the guest of honor. First, I would like to give it to Dr. Omar Chande, his gift and gift for Dr. Umi Mwalimu. Dr. Mabula, please help us. So that is a gift that we hope you'll send it to Dr. Umi Mwalimu, and this is yours. And one for the chairman, Ambassador Daniel. Thank you so much. Now we're going to... Thank you, Farida. She's a superstar. Yeah, so we would like to welcome the three keynotes to also come and sit at the top here with the guest of honor, that is Professor Ben, Professor Petra, and Erasto, as they get ready to give their keynotes. Karibuni. There are three chairs, you're all fit, it's fine. Karibu. Okay, so the first keynote we have is Professor Ben Wachira. Professor Ben Wachira is an assistant professor of emergency medicine with a deep commitment to improve the emergency care in Kenya. He currently serves as an emergency medicine program director at the Aga Khan University in Nairobi. There he trains future EM providers and plays a really crucial role in shaping the direction of EM in Kenya. You should know that Professor Ben is a founder and ED of the Emergency Medicine Association of Kenya, and is an organization just like IMAT that focuses on capacity building, knowledge development, advocacy for EM in Kenya, and research strengthening in the whole EM system in Kenya. Dr. Wachira, or rather Professor Wachira, is a past president of the African Federation of Emergency Medicine, that's AFEM. Where he worked tirelessly to advance emergency care through African continent. He's a prolific writer and has published widely in EM care all over the world. His research had led significant improvement in EM care, not only in Kenya, but also in Africa. Karibu.
Thank you. Morning, everyone. I don't like podiums, but I guess there's no roaming mic. How are you? Habari za asubuhi. Fresh. Fresh, welcome. Good. Good to be in Tanzania. Congratulations to Peter and his team for getting this together. As Peter always asks, do you have a presentation? I was like, yes, we'll wing it. Don't worry. All right, so my topic today is about policies, and something I'm very passionate about, and I'll explain why, and give you a bit of background of what I do, what I've been doing, and why you should be doing the same. So maybe I will just start by asking healthcare providers, put your hands up. Straight up, be proud. All right. Keep your hands up, calm down, keep your hands up. Now, how many of you trust the hospital you work in will save your life if you ever collapsed on the corridors? Keep your hand up. If you trust your life saved by the hospital you work in, yes. Those ones working in Africa, Americans, please, come on. Anyone out of Africa, yes. How many hands are left up? I'm only seeing the hands significantly disappeared. All right. So, and a lot of you potentially are emergency people, and I'm sure you can resuscitate a rock to start talking and walking. You're really good at your job. But unfortunately, you can't resuscitate yourself. All right? And so you provide a service you will not get when you need it. Okay? Other question I'll ask. If someone in your household, let me leave it that way, collapse right now, would their life be saved? Okay? If someone was choking in your house, do you think their lives will be saved? Will there be an ambulance? Is there an EMS number? Okay? You can save their lives. You are standing there. But right now, since you are in Grand Melia, who would be saving their lives? Okay? So it's a question I asked myself many years ago. And I'll be truth and honest. I just left ICU a couple of weeks ago. I was in ICU for 3 weeks. And I did collapse in my own hospital. And they did save my life, okay? So testament to the work we've been doing to build the systems. So a lot of us as healthcare providers are very good at what we do. We train hard. We become the best, okay? We can resuscitate anything that walks through the door. But we are very reluctant to engage in policy development, very reluctant to get into administration, and are only happy to just deal with the patient in front of us, okay? And which is a big problem. And I think a lot of the EM development on the continent was driven by partners coming in from the West. But the West has systems, okay? The West has systems where then now the focus is just treat the patient in front of you. The rest of the system works, okay? But in our setting, unfortunately, the patient in front of you is the only one who will benefit from your care. The patient next to them will probably die because you're busy focusing on this one, and there's no one to treat that next patient. And we've done a lot of focusing on EM training development, which is great, and have developed healthcare providers like you, which is great, but unfortunately have not moved the needle in terms of are we saving lives as a healthcare system in total. And these were the challenges I faced when I came back to Kenya in 2012 after my training in South Africa. And I remember having a chat with my director and telling them, well, I could sit and see patients in cubicles. That's great, okay? I mean, and each patient I see will benefit from my care. Fantastic. But what about the rest, okay? Who will take care of the rest that I am not seeing? How will their lives be saved? And the discussion at that point was, let's focus on building the emergency healthcare system within the hospital and less on what how many patients Benjamin is seeing, okay? And that's what we did, and I've been doing for the many years I've worked at the Aga Khan. Bosses have come and gone and keep asking, what exactly do you do? You're a doctor, you don't see patients. Yes, I don't see patients directly. My job is to make sure that every patient who comes to the emergency department gets the best care possible and their lives is saved where we can. And that's the objective. But how have we done this? Yes, there's a training part of it, okay? But more importantly, because healthcare providers come and go even within the departmental level, but what are the hospital, do you have a hospital, how many of you have a hospital policy on emergency care? I see no hands. How many of you have a hospital policy on resuscitation? I see no hands. So again, the assumption is people know what to do, okay? But unless it's documented, my friends, no one knows nothing, okay? You have all the knowledge in your head, but unfortunately, you're the only one who possesses this knowledge, okay? At the Aga Khan, we've developed significant systems and documented every single process that should you collapse, even on the streets outside, well, not outside Aga Khan, in the car park, there's a process for that. There's a process that there's a whole team that will respond to you. And this is documented, put in policy, tested, trained, and continuously improved on to make sure that the system never fails, okay? So building that system, documenting that system, ensuring everyone understands that system, and everyone means even the cleaner at Aga Khan knows if someone collapses, this is what I need to do, okay? And this has gone through by building the policy. Yes, a few people are trained in resuscitation. The cleaner may not be that good at CPR, we try, but sometimes not that good. But he knows exactly what to do to make sure that this patient will get the care within the time period. But the important part of this, beyond building the system and documenting the system, is the hospital appreciating the role emergency care plays. Because everyone thinks emergency care is just the emergency department. But across the entire hospital, patients do collapse, patients need emergency care. And if you've seen, sorry for ward people, if you've seen ward people try to resuscitate a patient, yes, it's normally quite dramatic. But if you're in the hospital, why do you have a whole emergency department and a whole emergency team, so why are you giving people pressure upstairs to resuscitate patients they really do need to be resuscitating, and there's help available. So by developing, working, and this is not you sitting and writing the policy, well, you'll sit and write it, but then working with the entire hospital administration, working with everyone to these policies, ensures that the hospital recognizes the role emergency care plays, and this expands from individual patient collapse to disaster management and mass casualty incident management within the hospital. The hospital allocates funding. Money is important. Do never ever lie to yourself. Allocates funding for all these processes, the staff training, then there's justification to train more staff, whether it's on mass casualty improvement, management, whether it's staff training, individual staff training, because this is all enshrined within the hospital policies and procedures to make sure that at the end of the day, we are safeguarding the lives of all the patients, not just the ones in the emergency department, all the patients coming through the hospital. Similarly, of course, you always have the fights between the emergency department and all admitting clinicians. It's a constant. You will always be fighting. Please come see your patients. Please come take your patients. Yes. But again, by documenting the process, sitting in meetings, having to explain to them exactly what you do, putting every single process. We have I think it's like a whole 50-page manual for every staff who walks into the emergency department. There is a step-by-step guide of orientating them into the emergency department, all the procedures, processes. They have tons of administrative exams they have to do before they are allowed to see a patient. And again, this goes through from the documentation processes. And you start with one document, you keep building up. So don't think you'll never do this all at a time. But you'll do one at a time, and you build up to we have a whole A&E handbook, which every staff has to go through. And we keep building up on it to make sure that every single person in the department is well oriented on how to provide emergency care. And note, none of these things I'm talking about are about the clinical protocol for managing heart attacks. No. Those ones are what you do in training, and those ones, they're in an algorithm somewhere. We developed actually a lot of those algorithms. But it's more about the administrative parts that we ignore, the policy parts that we ignore, the understanding of the processes and procedures, because the A&E the emergency department is quite a chaotic place to be. And getting a staff off the streets and just putting them there to work there is a disservice to the staff and to your team and to your patients. So making sure that you have a proper orientation process is important. So that's on the documentation and policy development at hospital level. And some of the policies you can look at developing things like a triage policy. For example, every patient walking to the hospital must be seen by a healthcare provider within 5 minutes of arrival into the department. So what's your triage policy, patient reception policy? What's your policy on just patient care? We have a turnaround time to say no patient should be in the department more than 4 hours, for example. They need to be out of the department and admitted or wherever they're going. What's the policy on patient care within the department? What's your policy on resuscitation within the department? What's your policy on resuscitation for the hospital? What's your policy on mass casualty management? What's the procedure for this? What's your, let me see which other, we have so many of those policies, yes. What's your policy on infectious disease control within the department? What's your policy? Now we actually now have, we've gone now to the depth of specific, what we call clinical protocols, which still are also in policy for heart attacks, strokes, to make sure that by the time you get in, within, at least for a heart attack, you should be in the cath lab within 20 minutes of an ECG being done. That has to be in policy, that has to be protocol developed, and training has to happen. So there's a lot of these policies, and you develop them as you go along and understand where are your gaps in your systems. And the objective again is, should you collapse in your hospital, should you collapse in your department, they should be able to save your lives. You should be able to get the same care you offer your patients at that level. So that's the hospital perspective. So let me talk now more on country level perspective. So I came back, so my research project, which I did around 2010, I went around the country and spent 24 hours sitting in at least 16 major public emergency centers across the country, just to observe the care that was being provided, or the lack of, and understand how emergency care was being practiced in a country which did not have emergency care established at that point in any format at all. And it was shocking, okay? Having left a system, well, I was training in a system where to die was made it very hard. Like, if you died, your maker was calling you, but if your maker was not calling you, the system took care of you and you left the hospital and you survived. And from that experience, I realized that yes, it's good to develop and train individuals, but if we're not gonna fix the system, then everything will remain broken and we will not achieve what emergency care is supposed to achieve, which is save lives. And the other part of it that people need to appreciate, and you all need to appreciate, is emergency medicine and emergency care is a system. It's not an individual, it's not a handful of people, it's a system. Patients do not get sick when they show up at your bedside. Patients started getting sick in their house, okay? They started feeling unwell. There was a lot of calculation of, can I go to hospital? Am I afforded the time? Will I be fired from my job? Do I have money to go to hospital? Those are decisions being made before your patient showed up at your bedside. When they finally decided they're too sick to survive or to stay in the house, then the next decision was, how am I getting to hospital? Do I walk? Can I walk? Do I take a boda? Can I afford? Can I survive? Do I call an ambulance? Can I afford? How much will the ambulance cost? Is there an ambulance? So these were factors being decided as this person is still sick and trying to get to the hospital. Eventually they find a means of way to get to the hospital. Whether you've provided one or not, they will eventually get to the hospital. They get to the hospital, they have to choose, which hospital am I going to? Can I afford the hospital am I going to? Do I even know the right hospital? Most will just say, let me go to the nearest hospital. So here you are having a heart attack and you're in a health center in the middle of nowhere. Is that hospital going to save your life? They don't know any better, so they will just go to the nearest hospital. So they'll go to the hospital A, they know, B, that's nearest to them, C, they can afford, okay? And D, their friends have told them that's the best place to go. So these are all individual decisions that patients have to make in our setting before they finally show up at your bedside. And I'm not even going to talk about the reception process within the hospital, which is as dramatic as it gets. But so by the time you're seeing a patient and asking them, where is your pain? This patient has been juggling decision making from way many hours before, plus minus. Compared to a system where, and this I'll use the 911 system in the US, where the only decision I have to make, okay, this is a bit tricky even in the US, but is, do I know how to call 911? Once I make the call to 911, I don't have to think about anything else. This is assuming you have money. America is also having problems. I'll dial 911 and just sit. An ambulance will show up. They will start providing care for me in my house. They will decide where to take me. I don't even have to think whether I have money or not, at that point, assumingly. I will be taken to a hospital. I'll be received. And they will get, as in, you do not have to think at all in an American system, or even the UK system, or the US, or European systems. The only decision you need to make is dial 911. That's it. Everything else will be catered for you to the end, yes. And then maybe billing will show up a bit later. So it's different in our continent. Anyway, back to what I was saying. So I realized, yes, we need to build a system. We need to build an emergency care system at country level. And we need to build a 911 system in a Kenyan system. And in that phase, so this was around 2012 or so, that phase is when we started thinking, with a few friends, of setting up the Emergency Medicine Kenya Foundation. Initially, we were excited about just training healthcare providers. And to be honest, our mission and vision has morphed into a more holistically, which is what I'll explain at the end, what we do now. But we started talking about emergency medicine and looking at how do we build the emergency healthcare system. Yes, there are already healthcare workers working in emergency centers. So our initial phase was, let's educate them. Let's provide them with the protocols and the tools. Let's make them understand emergency medicine and how to provide emergency care. You do not need to be an emergency physician to provide emergency care. You need to be a healthcare provider holding a good protocol and understanding what you need to do. That's what you need to be to save a life. And so we started with that phase of really trying to educate people, but it being a new field, the emergency medicine was not even recognized as a specialty in Kenya at that point. It being a new field, we started being pushed to do more and more and more, and started getting into government space, where we started being asked by government to start talking about, start doing something to fix the system. And so a few things happened. So in 2010, this was, I guess, just before I came back, the Constitution of Kenya was changed. And in that constitution, the two rights that every Kenyan was entitled to was the right to emergency medical treatment and the right to reproductive health. And that was just left as that, okay? They didn't define how that was going to be provided. Nothing else was done beyond that. But so when I came back in 2012, we started working with the Ministry of Health to start looking at how are we going to do this? How are we going to provide the emergency treatment? And I can tell you, when you start working with policymakers, there are many things that people need to understand, and this is lessons I've learned also, is many people think making is hard. Yes, it is hard. Okay, that's the truth. Many people, okay, I don't know that there are many, how many people believe your government is not working? You can just smile, because just in case you're being noted. But the truth is, government works. And I know, because I spend my days working a lot with. So Kenya was devolved into a national government and 47 different county governments. So I work with 48 governments. And it's painful as it is, government works. It just doesn't work the way we think it should be working. It doesn't work the way corporate works, private works. And there's a lot of learning that one needs to do to understand how government works. And it's a painful process, but once you have that understanding and you sit and listen to the policymakers and to the politicians and have regular dialogue with these people, They're human like you. They also want their lives to be saved. And many politicians have collapsed and died. And I will always remind them, if you collapse in your office right now as a Minister of Health in your county, who is coming to save you? Once you have that discussion, now you sit down and start really thinking about it and developing. And the other part of it is now working to develop within the context of your environment. Yes, I'd love to have a 911 system operating in Kenya. But right now, some counties barely have an ambulance. So we have to start from somewhere. So there are multiple, if you've ever seen the WHO emergency care system framework, there are multiple components that need to be developed. And you start working, chipping up slowly by slowly as you develop each of the systems, working hand in hand with the policymakers, but documenting, again, politicians change per hour. Okay, they get fired every other day, there's an election and the whole government leaves. So the key part of it is writing this up as policies, and I'll explain the benefits of policies, both at national level and county level, and really documenting all this process as you go along, having the county guys sign it off, because once something is signed off as policy, it doesn't matter who is in that office, it is policy, and that's what gets then implemented, even in its most rudimentary form, but have it documented. These policies normally are written to be improved year after year after year. So as we review the policy, we can move to the next level and the next level. But do not write things also in those policies that are unachievable. Start with what is there, what they can do, and then slowly move on to start being aspirational based on how things are developing. And so Constitution 2010 has the emergency care and reproductive health. And then there was a lag, okay? So we pushed and pushed and pushed, having tons of meetings, yes. Please be prepared to have multiple meetings with government. This is not it's not an email or one Zoom call. No. You will meet, and you will meet. And so we said from 2012, we're working on the national policy, on Kenya Emergency Medical Care Policy. And we worked, having tons of meetings. And trying to get everyone on board, ministry, and the many factors, this treasury and all the other people that need to be involved. And the good thing, so as we were working on this, we were also involved in the Health Act 2017. So there was a change in the Health Act, in the Constitution 2017, which further went ahead then to demystify more about what kind of emergency care is required. And they put in clauses such as, if you're a healthcare provider and you refuse to provide emergency care, then you're medically liable. And if you're a hospital and you refuse to provide emergency medical care, then you're liable up to Kenya shillings 3 million, which is, I don't know, $30,000 or something. Yes. And so there was further definitions about the liabilities of not providing emergency care. But there are still gaps in what is emergency care. It is never, we all know surgery, we all know pediatrics, we all know whatever other specialties there, but there was no specialty of emergency medicine. But this slowly gets, again, through a lot of lobbying, the Kenya Medical Council in 2017 also, I think, recognized emergency medicine as a specialty. Even if there are no training programs in the country, they did put it in their list of specialties that emergency medicine is a specialty. And then that, of course, opened the doors for any emergency trained person to be recognized as a specialist in the country. There are pros and cons of this. But again, back to legislation, back to documentation, back to policy. So the Kenya Emergency Medical Care Policy 2020-2030 finally saw the light of day in August 7th, 2021. We finally launched with the Ministry of Health, and this was the first ever policy in Kenya, but even across the continent. I think it was one of the first. There are many countries have a policy on emergency medical care. So it's the first policy that really well defined this was backed on the basis of the WHO Emergency Medical Care System framework, but detailed what we're talking about emergency care. So Constitution of Kenya 2010 talks about emergency care. Health Act 2017 talks about emergency care, but the policy now by the Ministry of Health then now specifically went into detail about What's the scope of emergency care? What does emergency medical care entail? What are the components? How is this going to be done? And within the same, there was a strategy done, Kenya Emergency Medical Care Strategy 2020-2025. Policy documents approved by the government, launched, that went into details and put money, budgetary allocations to this process. This was great. This was significant progress to what we were working. And that opened a lot of communication, both at national level and at county government level. And just maybe to explain how our system works. So national's role is to write policies. They do not provide healthcare at all at national level. Healthcare provision is a responsibility of the county governments. So while the national has done its job, now we have a policy. So you can't blame government for not working, okay? But it's not their responsibility to implement that policy. It's not their responsibility to make sure that emergency care gets to the common wananchi. And so from that point in 2021, we now started as an organization to work with the county governments, because now we need to work with all these 47 county governments to take the national policy, adapt it for the county government level, have them approve it, have them budget for it, and be able then to have county government emergency medical care plans. So far we've worked, since 2021, as I said, it's a process. We've worked with, I think we're almost at 20 county governments, and have had 10 are finally approved. The others are in the different stages of approval. And as I said, with government, it takes time, and there are too many changes in government. But what we've learned again through the process is, even at every county government level, is every county is different. Every county has different challenges. So it's not a copy-paste kind of system. But more importantly is the process of how money gets allocated for specific services at county government level. Without any policy, no one is allocating money for nothing. Okay? Government doesn't allocate, it's not just chop money here, okay? Government only allocates money to documented processes and documented policies. So if a policy does not exist, there is no budgetary allocation to that process. So when you keep asking, where is the government not investing in emergency care? Government is a body. If he has no reference documentation, then there's no money that's going to be allocated. So that's why your systems are not developing. And so we realized that the importance of us working with the county government to develop these policies, to put budgets for these policies, and having these policies launched has led to significant, really growth in emergency care systems at county government level. The helps the county government to, number one, understand which are the emergency care centers and start allocating training budgets and emergency department development budgets. Number two, a lot of dispatch centers now are being set up in many of the county governments purely because there's a policy that says we need to set up county emergency dispatch centers at emergency centers. Ambulance services are being developed at county level. But even for that now, we actually have to work again with the county to develop a specific policy. Everything needs policy. If it's not documented, it's hearsay, okay? And as soon as the current government leaves, the new one comes and they're like, you did what? There's no, by the way, that's one other thing you really learn from government. There's no handover. When an office bearer is kicked out of office, they leave. There's no handover process in many government processes. So the only documentation that will exist is a policy that you worked on. And in many instances, for example, we'll have one county government come and leave. Then the next county government comes and they're like, what policy? We're like, here is your policy on we're giving them back their policy, and then there's a further discussions and we move on in development. But these policies then help us to strategically look at how are we training, how are we developing the emergency departments, how are we developing the ambulance services at county government level, how are we training the providers to make sure they can provide that emergency care and build on that, okay? And so that is what we've been doing. So the Emergency Medicine Kenya Foundation essentially works with governments and emergency healthcare providers to strengthen the emergency healthcare systems in Kenya and save lives across the country. And my call to all of you again is to think about it when you go back. Yes, you're a great emergency care provider. You're the best, the best. But again, how much influence do you have in terms of how you develop your systems? And also, will your life be saved where you work, in your neighborhood, in your country? And I always say, my job mainly involves building the entire emergency healthcare system in the country to make sure that no matter where I am across the country, even if I collapse, not just in my hospital, at least they'll keep me alive long enough to get me back to my hospital. That's my hope, okay? To make sure, maybe they may not see me, but at least they'll keep me alive long enough to get me back to my hospital, for maybe then they'll save my life. But it's something that we always need also, it's something that we all need to think as healthcare providers and start getting engaged in policy development at facility level, regional level, country level, because that's the only way we're going to end up with a 911 system similar to what our 112 system, and essentially emergency healthcare systems that save lives in the country. That's it. I don't know how much time I have. Happy to take questions. All right, happy to take them later. Thank you.
You connect up? Okay. Do you have a presentation? Okay, just supposed to connect you. Sorry. So. Okay. As I said, I've been advised that we note all the questions we have for all the keynotes, and then we'll take questions after they're done. With that said, I would like to welcome the second keynote, who is Professor Petra. Professor Petra is a fellow of American Academy of Nursing in South Africa. She's the president of Academy of Nursing South Africa and a member of Academy of Science South Africa. She's a founding member of African Federation of Emergency Medicine, where she's still actively and most is involved in a lot of nursing programs. She has worked with research and education in health profession, primarily in nurses in South Africa and in Africa over the last 25 years, predominantly in areas of acute and emergency care. Professor Petra is the editor-in-chief of the International Emergency Nursing Journal. You're most welcome, Prof.
Thank you very much, and thank you very much to the organizing committee for inviting me to be here. All protocol observed for our distinguished guests. And welcome to everyone, and I hope that there are nurses in the audience. Just before I start, I wanted to echo my colleague's words, Ben, in saying that policy is really important. It's really important for nurses as well. I've actually, with another organization, been developing a policy toolkit because I decided that I didn't understand this policy thing. And it really is important for each individual. It's not just something that happens at higher level, but it really is something that each of us as healthcare providers should be involved in. So I'm just encouraging you to go and have a look too. So today I'm going to be talking about nursing emergencies, basically around navigating the current challenges that we face as emergency nurses in Africa. So first of all, I'm just going to remind you about things you already know about our continent. but sometimes you sort of forget about it because you are here, but it's important to think about it in relation to what's happening in the rest of the world. The fact that we're the second largest continent and we are very heavily populated. We have a young population. And many of our healthcare systems, unfortunately, suffer from neglect, underfunding, etc. And we also are the region that has the lowest number of healthcare workers. I'm sure you're all very aware of our road traffic issues that we have, and we lead the world in this, unfortunately. We have different types of roads with different types of challenges. I was just reflecting on it with my trip here this morning and watching everybody without helmets on their motorbikes, and imagining all sorts of mechanisms of injury. In my country, the minibus taxi incidents are a huge problem for us, and these then are multiple casualties. We have problems with homicide rates, again, very high. We have HIV, especially for me, I come from KwaZulu-Natal in South Africa. Huge issue for us, which really affects the healthcare system as a whole and for us as emergency care providers. And then, of course, we have our pandemics here in Africa, which makes an already existing challenging situation just worse. Right, so let's talk about nurses, because that's what I wanted to be doing here today. And it's already been mentioned that, you know, emergency care is a team sport. It takes all of us to create a successful emergency care system. And nurses make up approximately 60% of the world's workforce. And they deliver almost 80% of the hands-on care. Nurses are often the first and sometimes the only person that the patient will actually interact with. And nurses provide care and support for sick, injured, dying, detect illnesses, administer medication, treatments, do all sorts of things. And definitely it's been said that nurses are at the heart of the world's current health priorities. If you want to solve a healthcare problem, you have to go and involve the nurses. There's no other way. I thought I would just share this with you. It's our nursing meta paradigm. And sometimes it's just useful to show just what we mean when we say that nursing has a comprehensive approach. And it's really because nursing is about this multiple interconnectedness between the person, the health of the population, the environment, as well as the nurse and the nursing profession. So nurses are the backbone of a healthcare system. And that's especially true in emergency care. And with the increasing demand on the African emergency healthcare systems, it means that the development of emergency nursing has huge potential to really harmonize these standards of care, to really improve emergency care for our African populations. So what do emergency nurses do? It's really a speciality of nursing where they care for patients in the emergency or critical phase. It focuses on the level of severity and time-critical interventions. And a huge part of emergency nursing is this collaboration with the rest of the team, pulling all the different stakeholders together and creating some kind of order in that whole situation. So as you all know, Emergency nurses, emergency care personnel work in very unpredictable, uncontrolled environments. Oftentimes we have very aggressive or hostile patients or their families. We have fluctuating levels. You can have extremely busy emergency departments and suddenly it becomes quiet. You have lots of non-urgent patients and suddenly very critical ones. And the continuum of care is extremely broad, so that you really have to be this sort of advanced generalist, because you never really know what's going to walk through the door. And on top of all of this, you also have to deal with mass casualty incidents from time to time. So let's look at the sort of the challenges that are really facing nursing. And one of the major ones is around the shortage of nurses, and difficulties with recruitment and retention of nurses. I travel a lot around the world, and I go to many different places, and it doesn't matter if you're in the most developed, affluent societies or the least, they're all complaining about the same thing, that there are insufficient number of nurses. However, as you can see from this, we are really in the problems with how many nurses we have. And WHO has said that we have probably to look forward to 10 million health worker shortfall by 2030, and that's especially going to be true for the low to middle income countries. So it doesn't sound like things are necessarily going to be improving anytime soon. This was also just to show the density of health professionals. So the first, and I've circled the African region. The first block is around medical doctors, and the second is nursing and midwifery. So we really have got very few healthcare providers compared to the rest of the world. And all the nursing bodies everywhere is saying that there really is this shortfall of nurses, and it is a global health emergency. And so these global trends really are influencing the quality of patient care. In the US, they say their shortages is really more severe in the rural areas. And in sub-Saharan Africa, this shortage is really influenced by the lack of sufficient nursing schools, unavailable resources, and sort of other various economic factors as well. I'm not trying to make you all depressed. I'm going to tell you all the challenges, and then we're going to talk a bit about some of the solutions of the way forward, okay? Right, so then just to talk about the education and training challenges. So there are, and there is very diverse training that's offered on the continent for nurses by both public and private entities. But it is important to note that advanced practice nurse training in Africa has been around since the 1980s. So nurses have been specializing in a variety of different things for a long time here in Africa. And countries have got standards for health professional training, but not for specialized nurse training. So it tends to be quite variable between the different countries and different areas. We have limited doctors and nurses who are trained in emergency care in low to middle income countries, and limited number of trainers who can, or training institutions who can actually carry out this training. And often our nurses and other healthcare providers are being trained using very limited resources. We also, within nursing specifically, have got substantial differences between the titles, modes of education, the scope of practice, the recognition of nurses and midwives, across the continent. And for emergency nurses, there is no consensus on sort of the minimum level of training, etc., for us here. We also don't have delineation of roles and responsibilities. And it is impossible to obtain the numbers of specialist emergency nurses in Africa. I say that because I've tried. It is near impossible because it is not documented. So we know that there are emergency nurses being trained throughout Africa, and especially in the last few years we've really that's increased quite substantially in a number of countries, but it's just not possible to get the numbers. And I've just reflected here Kenya, Ghana, South Africa, and more, where the training of emergency nurses is growing. I always like to just throw this in because it does make me wonder what healthcare is going to look like as the robots and AI take over. And it is important for us as nurses to think about how we're going to remain relevant as practitioners of nursing. I always joke with the trauma surgeons that I work with, and I tell them that it's a good thing that they're getting old and retiring, because we're not going to need them soon. We're just going to push patients into a little tunnel where the little robotic arms will do the surgery. But jokes aside, we don't know how this is going to change healthcare, and I think we have to think about how we need to reframe our education and how we need to prepare our students for the future where AI, etc., are integral parts. We also have the younger generation that has different ideas. And in nursing, this definitely has created difficulties, and difficulties across the world. I was recently in Japan, where they were saying to me, what do you do? How can we have more nurses? These young people don't want to come into nursing anymore because it's a hard job. I always joke to my students that it seems that the job for young people is to be a YouTube influencer living in a van next to the sea, because they all seem to aspire for things like that, and that nursing is too hard. But the reality is we have to think about the work environment and whether we need to make changes around making it a place that is attractive to the different expectations of our millennials, etc. Right, so just wanted to look at the scope of practice challenges, and these are the problems really are around it being very unclear and very different across our different countries. Right? We all do things very differently. When we first started looking at emergency nursing in AFEM, and we wanted to develop a framework for emergency nurses in Africa, we realized that we don't even agree with what a nurse is across these countries. Because nursing training, just as a basic training, happens in some countries from high school level, and in other countries you have to finish high school, etc., and have it at a degree level. So there's great variation across countries. So there's inconsistency in terminology across the African countries for these levels of nursing across the board. Unfortunately, there's often disrespect and non-recognition for nurses by other multidisciplinary team members. I still have many people that say to me, are you sure you can be a professor? Did you really go to university? Or they say to me, but why did you want to be a nurse? You've done all this training, you should have just been a doctor. And so people cannot understand that nursing is a completely different job to medicine. It has its unique place in the healthcare system. Often, and especially with regards to emergency nursing speciality training, it's not reflected in the compensation. So why would a nurse spend all that time and money going and training when it doesn't mean they're going to be getting additional money or anything else from their workplace? It doesn't make sense. There are no standards for safe staffing in emergency care settings, and people have been asking me about this forever, and unfortunately there's still none. And very few professional organizations representing emergency nurses in Africa. Our nurses work in many different environments, so it can be extremely primitive kind of environment to extremely complex. And again, sometimes working with very outdated, limited equipment. It's very hard to do your job if you have very little equipment to do it with. And also working with multicultural challenges in a number of our countries. This is very true, and definitely for mine, where sometimes the doctor, the nurse, the patient, and their family are all in different cultural groups, different language groups, and it creates quite a challenging environment. So a student of mine did this interesting study where we were looking at professional isolation, and that just really means feelings of being isolated from your own professional group. Okay? And he's finished now, my student was from Lesotho. So emergency nurses who were trained and went back to Lesotho would often find themselves alone in a hospital, very far from all the other emergency nurses, and they were talking about how this made them feel very isolated, that they felt very alone. Here are just some of the things that they were saying, and that it's about the fact that they've developed these skills that the other nurses they're working with don't have. So when they start wanting to do something in a certain way, the nurses are saying, why are you doing that? What are you doing that for? And it makes people feel very isolated and alone. It's also important to think about how the different healthcare professionals in the emergency department work together. And people have done lots of research around communications in emergency care teams, about how doctors communicate, about how nurses communicate. And these are some colleagues from South Africa that were looking at uncovering patterns and relationships in the data to see how doctors and nurses were making sense of particular situations in the emergency department. And it's really interesting to read these kind of things because it really shows how we are quite different. We are educated quite differently. We make sense of a situation quite differently. And here, the doctors and nurses prefer different types of communication methods, that they often had disjointed and disconnect between the way in which they communicate with each other. And while they're working in this shared space and caring for the same people, sharing the resources, just fundamentally understanding and communicating differently can create lots of difficulties and conflict sometimes. All right, so what am I seeing as perhaps some of the ways forward for all of these challenges that I've mentioned today? So there's been lots of research and lots of people looking into ways in which to address this nursing shortage. And here they've given their sort of top 6 of ways to start to tackle this. So one of the first top of their list was around listening to nurses' concerns, because it's very important that we keep the nurses who are already there, because we know it's going to be hard to replace them. So it's about keeping those ones that are there already. So listening to their concerns, and allowing the nurses to feel loyalty to their system, that they are of value. So when you have long-term nurses who see that their facility is offering higher pay and more flexibility to new people, then that doesn't make you feel very happy that you were one of the ones that stayed there for a long time. It's also about prioritizing the workplace culture. So it's not very nice if you are made to feel that you can just simply be replaced. Okay? We want the workplace to be one where frontline people, the nurses that are there, feel that the organization sees, hears, and values them. Because you need to. You don't want them to leave, because it's going to be hard to replace them, and it's going to get harder and harder. So, as I've said here, retention needs to be top priority. And training and preparing future nurses for where they are most needed. And that leads quite nicely into WHO with their 25 by 25 by 25 campaign, where they're really serving to highlight the importance of basic emergency care and how all nurses should have basic emergency care. And I think it's a really good time for us as emergency nurses to leverage off that interest in emergency care and emergency nursing to really help to push the speciality forward. So IFEM and AFEM working together have been running the BEC training throughout Africa, and I really commend the colleagues who have been working hard at this. And just to show that, you know, since BEC was, the Basic Emergency Care course was started, AFEM has successfully trained 2,715 nurses across Africa. So the African Federation for Emergency Medicine has really been working hard to upskill our nurses in terms of emergency care training. So I think it's also important to ensure that with our specialist nurses that we define their roles. Because what often happens is that our nurses in Africa might train in other countries. They might train outside of their African country on the continent, or they go further afield. But often when they come back, everybody gets very excited and says, "Oh, that's marvelous that you've come back," and they pull them away from where they have been trained to be. So oftentimes into leadership positions, oftentimes into all sorts of things, and we don't get to utilize their skills in that particular area where they've actually been trained for. Some of the nurses have said it's about being pulled in different directions. They say, "That's great, you've now done your emergency nursing training. You need to come and help with this management. You need to sit on the hospital ethics board. You need to be here, you need to be everywhere," except in maybe the emergency department where we really need them to be. And role confusion about if you're a specialist nurse in Africa, what you're actually then supposed to be doing is really one of the greatest threats for us in terms of specialist nursing roles in Africa. And this is just, there's lots of work that's been done around this and around how, what sort of can enable these kind of role expansions and how we can further advance the development of this and what the enablers and barriers to this are. And I really would just encourage you, if you are involved in specialist nursing training, please go and have a look, because I have many people that tell me how they've started these courses and it's so amazing and it's all very exciting. And when I see them 2 or 3 years later, they're telling me all these problems. So please prepare for them ahead of time. One of my own personal crusade and lots of other people is really around developing a clinical career pathway for a nurse. That was the major reason why I left clinical practice, is I knew there was nowhere else for me to go except being a shift leader or being a unit manager, and I wasn't particularly interested in that. So I had to leave and ended up in academia. But we want to keep our specialist nurses in the clinical area, but in order to do that, we have to create positions for them there. And some of the options are to create this kind of portfolio career where they can do a number of different things, so that they can do some teaching, some research, etc. And in some countries, they've done that really well. And just a mention to always think about burnout. That's also one of the reasons why a lot of our healthcare providers end up leaving. So I always like to just mention about nurse champions. In Africa, we have got lots of amazing nurse champions, and I'm sure, and they are in this country too. And they are these change agents who are doing amazing things in their areas of work. And we want to just keep finding those nurses and helping them and supporting them and encouraging them to grow and to be the future leaders of our profession. We know that nurses are traditionally seen as the hackers of the hospital. Nurses can always make a plan, and there are numerous examples of how good nurses are at doing this across the world. I want to just also leave this with you, that I think one of the ways that we can help improve things in emergency care and in our departments and in our healthcare systems is to really think about how we are involving families. We use families a lot in Africa. I would say that our healthcare systems would collapse if we took all the families away, because often they are the ones at the bedside helping the person eat, bringing food, turning them, because there are not enough nurses to do that. And lots of research has been done to show the positive outcomes of involving families, and things like reduced length of stay, overall improvement in health literacy, decreased use of hospital services. These are really important things that can save money for the healthcare system. And there's been systematic reviews that have been done around family participation in resource-constrained environments and how it can be effective and safe, in specific contexts. So please go and have a read and have a look. Obtaining feedback from our patients and families is also really important, but it's very seldom done in emergency departments in Africa. There's lots of problems as to what makes it difficult, but something we need to work at as well. So the best way for us to work towards our emergency nursing energy in Africa is around acknowledging the strengths that we have in our different countries and bringing our collaborative voice together to share what we've all learned and to really speak up about what's happening and what we can do going forward. Establishing our interdisciplinary support, because I believe we all need to be supporting each other in our work. And if I can, just sort of sending a shout out to AFEM and saying, please join up with AFEM, work together with us there. We have lots of emergency nursing champions across the continent. I'm just showcasing Emmanuel here from Ghana, and he's leading the emergency nursing group within AFM currently, and would really like to have the other nurses joining us and emerging nursing to see that this is where you can be heading. You can be the future leaders of emergency nursing in Africa. We've developed a number of resources to assist our colleagues on the continent, and we're always looking to develop more. So just in conclusion, that I've mentioned a number of the challenges that we have, and how where we are makes things quite difficult for us often. But there are many emergency nurses in Africa who are currently doing incredible work, and we want to really acknowledge and support them and their work going forward. I hope that we will see a number of you in Botswana in November for the African Federation of Emergency Medicine Conference. It would be lovely to have you there. And just thank you very much again for giving me the time to talk about this important issue. Thanks.
Okay, thank you so much, Professor Petra. Okay, the third and last keynote speaker is Dr. Erasto Silvanus. Dr. Erasto Silvanus is an emergency physician who graduated from Mumbili University of Health and Allied Science. He now works for the Ministry of Health, but before that, Dr. Erasto, after graduation, worked for one of the biggest hospitals in the zone, which is Bugando Medical Center. Now he's an acting director of Emergency Preparedness and Response Unit at the Ministry of Health, and that's in Dodoma, which is the headquarters of the Ministry of Health. You're most welcome, Dr. Erasto.
Is it
Good morning. The guest of honor, Dr. Chande, Honorable Olenjolai, and the rest of participants, Dr. Mabula, good morning, and the rest of the colleagues and participants of this wonderful conference. I was very happy to have seen Honorable Olenjolai here. I did not expect it. I was like, oh, he's around. And when I saw you, I know you can't remember this. You can't remember me. You might remember the scenario. When you were still the regional commissioner of Rukwa, it was between 2006 to 2011, I think. We came to you as senior medical students. It was around 2010 or 2009 or 2020, around there. When we were waiting for our issues, we organized ourselves. We were like 12. We had one colleague from Rukwa who was born there. He said, we can go to my region and we can support them. There are very few doctors there. Most of them do not want to go. They want to remain in Dar es Salaam, in Arusha, in Kilimanjaro, and Mwanza. We know we are not very experienced yet. We do not have certificates yet, but let's go. We wrote you a concept note, the regional commissioner, and you accepted, and you called us, 12 of us. Yeah, Mugisha. You don't remember Mugisha? Yes, we came there. He welcomed us from his office, as young as we were, but he listened to us. He said, what can you do? We told him, and then he said, then help us. We really did our job. The good thing is we started our practice very early in 3rd year. So by then we were very good at a lot of procedures. We could do cesarean sections then. We could stitch. We could run rounds. We could assist the doctor. There are no doctors there. There were maybe 2 doctors in the regional referral hospital, apart from the medical officer in charge, the one who was in charge of the hospital. He was a surgeon, but he had this other burden of administration. So we stayed there for around, if I remember correctly, like 4 or 6 weeks, around there. He gave us food, he gave us transport, he gave us the house to stay. So thank you very much for that. And when we were going home, he called his fellow leaders of the region. There was a ceremony, a farewell ceremony, and on top of that we had the khaki envelopes. You know what that means? Maybe some of you may not know. When you have a khaki envelope, it's either a letter inside or money, something to and so we just knew he can't write us letters here, and so it was a very good package we came back with. So thank you very much, Honorable Olenjolai. It was very nice to have you there and having seen you here. Yeah, so thank you very much. Even after your service in Nigeria, of course, we are serving, I think, other countries, like 12 other countries that you could, yeah, like 14 countries. It was in Nigeria, but you could serve other countries as our ambassador. So thank you very much for your service. I was introduced as the Acting Director of Emergency Preparedness and Response, but that has changed. Yeah, I was acting as the director for around 11 months or 10 months, I think. And now I'm no longer an a director for emergency preparedness and response. I'm now coordinating emergency medical services. So I'm in charge to establish EMS service in the country and run ambulance services. It is a new job. I have to try a lot to learn, to get experience from my colleagues from other countries. I went to Brittany. To Brit, were you? Yeah, there she is. Yeah, in Atlanta. I went to her just to ask about this. I'm kidding. It was just a coincidence, and I told her, what can I do with this new responsibility? And she was very helpful, and she we had something to start with. So I'm glad to have seen you again. When I came here, I just received a text. I said, how did she know I'm here? And then I remembered, Mabula might have invited her. Yeah, so I'm very glad to have seen my colleagues. Ben, you don't remember me, but we met when you, a few years, in my first year of residency, I think we met in Mwimbili and in South Africa in a conference. And the rest of my colleagues here, all of you, thank you very much to have seen you again. I'm starting with all this long introduction because I've looked at the timetable and I've seen I should have started at 11. And I have 40 minutes. And right now, I have additional 30 minutes. So I'm going to speak for 1 hour and 20 minutes, just to make sure you don't, I match with the time. Is it right? Mabula? All right, thank you very much. I'm not sure if my presentation is being projected, but let me just start. My job, or my presentation today was to share with you about the emergency medicine growth in Tanzania. It's just a short but a comprehensive review or overview of what we have so far, or at least where we came from. So the essentialness of emergency medicine is clear. Its immediate and life-saving interventions is We understand its role in as a gateway to healthcare. It is a face of the care of the hospital. When people go to the emergency department and get very good service, that's the starting of the healing. The starting of getting better. The way we look at, the way we receive them, the way we talk to them, the way we care for them, that rapidness and aggressiveness, they feel that they can make it, and that is one of very important aspects of it. Emergency medicine has been very important, even in outbreaks, in disasters. Yeah, we are usually in the front of every battle of healthcare. Emergency medicine is also the way we are trained. We are able to utilize very well the available resources, adapt to the scenarios and the limited resources. But also, emergency medicine has been, apart from the general life-saving, but we have been instrumental in the quality improvement of our hospital care. So I can't emphasize enough the role of emergency in Tanzania. If you look at where we came from, in 2010, I think that's when we established a fully functional emergency department in Muhimbili. And then is when we also were running residency programs. We started with very few emergency physicians, and we have been growing over time. Visible? Oh, there's two. Okay. Yes. So I said we started from there with one emergency department, and then a few years later we started other emergency departments at Bugando later at KCMC and Mbeya. So these are public health, these are public emergency departments. We also had emergency department at Dodoma. That's our capital of the national capital city. But then we have had a vast improvement or construction of emergency departments across the country. For the past 2 years, we have constructed new emergency departments in all regional referral hospitals in 26 regions. And we have constructed other 82 emergency departments in district, at the district level. Those are the district hospitals, the council hospitals. And this year, I think we are going to add one. So there will be 83 emergency departments across the country. All this is the progress that we have made over very few years, like 2 years, past 2 years. And currently we are embarking now on the introduction of emergency medical services. Of course, its role in the overall health care or health system is very huge. From where we started, oh, thank you. The training programs has also been continuous. Of course, the residence programs in Muhimbili, we've been having only one training institution for a long time, and we are thankful for another center at KCMC. Congratulations to Dr. Francis. Yeah, great job that we have at least established other centers for training. So from 2013 up to now, we have around 90 something, like 95 people. Of course, 87 of them were trained right there at Muhimbili. Well, the others are from elsewhere. But this has been a very huge progress, given that it is a very young specialty. It's still young, and we have surpassed some of other specialties that have been there for more than 50 years. Yeah? We have built this team very fast. So it is a very big commitment of the pioneers of emergency medicine, our colleagues some of them are here, and also we are trained by Brit, who is with us today. And we have run some short courses, the basic emergency care, the basic life supports, etc. We have trained around more than 3,000 nurses and doctors who have never been in formal emergency medicine training, just to have this package of emergency care. And we trained, when we started the emergency departments at the district level and the other regional level, who did not have emergency physicians, we had to have a crash program for our on-the-job workers to have skills and knowledge on how to run emergency departments. So we had that session for like 3 weeks in Muhimbili and Bugando. Thanks for our emergency physicians who trained our people. They got this training around 582 just for the regional referral hospitals, and almost bigger number than this for the regional level. So we, as a ministry, we still collaborate with the other partners and organizations, both locally and international, to develop more skills in the country. And we are expecting to also, with collaboration with partners, to establish training of, we call them emergency skills lab, yeah, or like center of excellency for hands-on training. They are going to be in our zonal referral hospitals like Muloganzila there. One will be in Dodoma, like the Benjamin Mkapa Hospital. The other one will be in Bugando and Mbeya and KSMC. So other regions, the neighboring regions with facilities, will be sending health workers there to train for a period of maybe 1 month or so, the hands-on practice, so that they can go back fast to continue serving the population. So we have come very far. This is the picture of how the emergency department at the at the district level looks like. Oh, was I going forward or behind? Okay. Here, yeah. I was looking for a pointer. This one? Okay. This is the classic emergency department in the district hospital. All of them look like this. And we have put equipments, we have put beds, we have put monitors, ECGs, ultrasound machines, warmers, etc. So this is one of the rooms that looks, this is how it looks at the district level. And we had these trained for, because they are already nurses and doctors, we just trained them with the philosophy of emergency care, and how we triage patients, we run the ABC, etc., so that they know at least what to do extra when you are at the emergency department. So this has been very helpful, and we understand the impact. We are going to talk about that later, the impact of having emergency departments which we have trained personnel. We have ambulances. We have both, as a country, the government of Mama Samia has brought in the new ambulances, more than 600 in the pool of 761 ambulances that we had. So for now, we are going to have around 1,360 something ambulances in the country. And then that one brings us to another challenge. It creates another problem, yeah, or another challenge to tackle. We will need paramedics, the people who will take care of properly of the ambulances, travel patients while they get some resuscitation or first aid while being transported, instead of ambulance running like msafara. Yeah. For now, ambulances are known for their speed, not for their the capacity to save a patient inside. And that one, Mabura, has affected even the people. When they look at the ambulance, they go at the speedometer. If they see it as a maximum of 120, they say, this is not an ambulance. I need the one that can go maybe 200, 180, yeah? But that's not an ambulance. Ambulance has to run slow, you know. A speed of 60 kilometers per hour is a very high speed, yeah? For you to do anything in the car. Maybe at least around that, 40 to 80, that's a lot of speed. When we were distributing these ambulances, one of our fellow called me. I said, what kind of ambulance have you given me? I said, what do you mean? This one, I'm told the driver could not go beyond 100 kilometers per hour. I would wish for another one. Yeah, I understood what he meant. because ambulances are known for speeding. But ambulance should have enough space, equipment inside, a nurse or any healthcare worker, a paramedic who will take care of the patient. The patient feels like they are already in the hospital. You know, they talk, you get your vitals, you know. They can even send some ECGs or some tests to the other colleagues in the hospital and say, look at this. Yeah? When we get to the hospital, they already know what you are coming to what they are coming for. So they just help you right away. So all these things have been happening over these 2 years. And so if you look at this map, we have emergency departments all over the country now. Yeah? And that one give us a bigger responsibility to make sure these services are not just there, but they are quality services. They are services that anyone will be proud to go seek. Even ourselves, we can go there and relax instead of calling our colleagues that they need to help us. So now, of course, it has been happening in Muhimbili for a little bit longer, but other regions or other hospitals has come with the telemedicine. We are sharing knowledge, sharing patients. In Bugando, see Ali's there. They were also integrating theirs, the telemedicine room. This is Juma and Patrick. They were also they were in their room for telemedicine. So we have put this in all the regional referral hospitals, and some of the all of the zonal hospitals and national level. So it is easy. Even in that some of the district levels, they can communicate to the referral hospitals for the assistance, for the consultation. So we need to integrate technology in emergency medicine. We understand we have had very good mannequins at Muhimbili, Bugando, KSMC, but we need to have all these mannequins to train, the hands-on, the simulation equipments to all the emergency departments so that they can train better and do all these procedures. We are very good at the point of care ultrasound, and we have put them in all our emergency departments. Some of the departments have video laryngoscopes. We need more of these in the rest of the regional referral hospitals. Of course, other procedures are very big, but we need to embrace all these procedures that can be done at BB's place. I did not talk about you. BB is is my personal mentor, and when I was talking, I did not see you. Yeah, and these are the things that for you, they are just maybe old school already, but we are still lacking them. We need to have all these things in every department, emergency department, even more. We need to do some advanced procedures right there with our teams. We can call maybe neurologists, neurosurgeons. Some of the procedures can be done as a team right there at the emergency department within 1 hour before they get taken to different places. So all these we need to have in our emergency departments. So having just these emergency departments that we have, when we just had one at Muhimbili for 2 years, it could reduce the overall hospital mortality, not just at the emergency, the overall hospital mortality by around 40%. So it was around 45. And we took this as a push, as a confidence that if one referral hospital or one emergency department can do this, what if we duplicate in all the regions, in all our referral hospitals? It means we can reduce the overall hospital mortality by that. Even half of it will be good enough. So that was why we were very confident at establishing these emergency departments. So we are sure it will improve patient outcomes and reduce the hospital mortality rates. And we have countless stories, people who were almost dying or almost clinically dead, yeah? But have been resuscitated and have come back from emergency departments. And some have been sending thank you cards, thank you to our colleagues in emergency departments that they did not think they would survive, but they have. So we understand the role of emergency medicine. but we still have challenges. Of course, challenges come with opportunities, but we have created the Human Resource for Health challenge. We have widened it, but it is necessary that we need to do this. Yeah? We have created a challenge of training centers. Now Mwimbili alone and KSMC won't be enough to feed these emergency departments with skilled healthcare workers. We need super specializations in emergency departments. We need more availability of life-saving equipment in all of our departments. Of course, we have a challenge of brain drain. When I told you we have around 95 emergency physicians trained in the country, only 53 are practicing in our emergency departments. Some have been taken away from greener pastures, or I don't know, greener environments. And some have been turned into policy makers. And some have just been given other roles. So that is still a problem. So we do not have 95 in the pool of emergency, but we need to feed more in the system. But we have potential opportunities as well with this growth. With this growth, we have a political will. The government is expecting us to give the plan. What do you need? Yeah? What are the best, the quick wins? What are the bigger wins? The government is listening. If it has constructed all these emergency departments, sure enough, it will need to equip it for quality care services. So we are not, we should not worry about what advancement you want to make. The government is already proven that it is supporting this service. We have a potential to train further and to train other junior nurses, junior doctors, and other colleagues of ours outside and inside the country. For last year alone, this academic year, we have the Ministry of Health alone has sponsored through Mama Samia sponsorship 601 in specializations. Not the first degree, the second and the other areas. For emergency medicine alone, I think we have supported maybe 20-something for this academic year. So we have opportunity to get further assistance. This one calls for more research. We need to know what our investment are contributing to the overall improvement of healthcare. We need to know how now the before and after, you know, like these 2 years or before, and we can start from this year going forward to 2 years and see how we have impacted the overall healthcare and the overall outcome of patients. We need to get more involved in preparedness and response, as we have been, to be more upfront. And even in the Manyara issue that happened, the landslide, our emergency physicians were one of the first people to respond there with ambulances, and they were leading the teams of the medical teams to serve patients and transfer them in different places. So they did a great job, and they were coming from your colleagues. So we thank all the teams that came from Arusha, from Manyara itself there, the regional hospital. Some came from Dodoma and Singida. So we want you to continue being involved in preparedness and response. There is a potential for continued investment and collaboration with the partners, because they've been there with us as we started. So the future, we want the future of emergency departments to have equipped facilities. This one, the one you see, this picture is this one. This is I think it was a trauma room at Brittany's hospital. Remember this picture? This is just one room with all these things for a patient, one patient. Can you imagine that? And it is just one room. They have other rooms with the same equipment, you know. But we can get maybe half of this, or even, you know, similar to this, so our patients can feel that they can get all the care they need. They can get all the service they need. We need establishment of very well out of hospital emergency care, like these ones. With the ambulance that we have, should have trained nurses. We call paramedics as a general term, but for us we can use anyone for now, because we are Said Kilindimo is working on that. I think we are going to have the formal training for paramedics very soon. Maybe if not this year, maybe make sure we have it as soon as possible, because the country cannot wait. We want these people to be taken care of by skilled ourselves, our brothers and sisters back home. They need to be cared with skilled people. So we need to have ambulances with these smart people, with uniforms, with knowing what they can do and save patients' lives. We need to do more research, as I said, and have more innovations. We need to talk to the people in the manufacturing industry, the business people, tell them what we want, so that they can try to make some of the adjusted equipment based in with our situations. We don't need to continue waiting for equipment bought from Europe, and you fail even to push a cylinder, oxygen cylinder, waiting for a proper, I don't know, the trolley. But we can make trolleys, we can make tables, we can make other things. We can do a lot of things in emergency to improve the care. So my time is still, I should slow down. Okay. Emergency medicine, I think it can change even, I don't know, mtazamo, tunasemaje? The perspective too. Kwa kama hilo lilikuwa linagoma hilo. Yeah, it can change the perspective, but even the how we work in the hospital. You know, when you are used to emergency departments, you are used to that environment, and when you go outside of that environment, you feel very angry. Do you understand? You feel angry for your colleagues, like sick, your mother and sister, your neighbors who are going to the hospital. You expect everyone to be like you, but it's not. You know, their philosophy, the environment of working is different. That's not how they are trained. They're not trained to rush. They're not trained to run here and there. But they are doing a great job. But your environment is completely different. When you are working as a team, a doctor and a nurse together, this one puts a line, and this one gives the medication. This one rolls the patient or covers the patient. The other one is taking sample to the lab. You can't wait for the lab technician to send you results. You fetch them. You know, that kind of environment can really change the outcomes of the overall care of our patients. If half of that is introduced in other departments, in other areas, they're not wrong, but that's how they are working. But if they can, that rapidness, that teamwork, that working together can really change the outcomes of patients. So emergency medicine extends beyond individual patient care. it influences the overall effectiveness and responsiveness of healthcare system in the country. And you who have been working in emergency departments are witness that when you give the best care at the emergency department, and when they go in another department, they can call you back and say, can you come again and help my colleague? Because not that they are not sure of the skill, they are not seeing that togetherness, that teamwork, that rapidness, and they start being worried because they've given them so good at the entrance, and like you are downgrading somewhere as they get further treatment. So I'm calling all of us tuwaambukize wengine hii tabia tu ile ya kwamba usijali wewe ni specialist, you know, wewe ni bingwa gani, lakini unatoa damu, unaweka line, mtu anakuja unaweka mask ya oxygen, wewe mwenyewe Mabula unamkuta anafanya vyote hivyo, anafanya all those things. We need that to cascade in the rest of our departments in the hospital. And if you can show that, yeah, they can feel that they can also do the same. With that, thank you very much. That's all I had to share with you in the growth of emergency department. Thank you.
Thank you so much, Erasto, Petra, and Ben. And as I said, we were reserving any questions and comments by the time all the 3 keynotes were done. So just put our hand raised, and me and the rest of the team are going to help pick, and we'll listen to your comments or questions.
Thank you very much, presenters. My name is Dr. Ali Akrabi. I have a question to Professor Ben Wachira and Dr. Erasto. To Professor Ben, thank you first for enlightening us on your talk. You being merely alone as an EM leader or expert in Kenya, what affiliations or human resource have you been using to advocate for the advancement of EM care in Kenya? And the question to Dr. Erasto, first we congratulate you for the work that you're doing in coordinating and supervising the emergency services in the country, and for leading us into the investment that has been done. We have seen a substantial investment in the areas of emergency care units, but also the critical care units all over the country. How are you going to coordinate these services in a package of the services that may be provided? We have seen some areas have been invested only an emergency care unit or an emergency department, but have not been invested on the critical care unit. But the others have been constructed the critical care department, but not the emergency unit. So what was the idea behind that? And looking at the challenge that there may be a vacuum of these critical patients that may be resuscitated at the emergency unit, what would be their exit plan or their continued care after that in an emergency unit alone, constructed in a hospital, and the others having only the ICU? I hope my question has been. Thank you.
So I think just taking question.
Thank you, all presenters, for nice presentations. I'd like to also to commend the work done by the Minister of Health, especially for what Dr. Erasto has explained, establishing these emergency departments in these hospitals. My question, I think, relates to what our colleague from Kenya said. They have a policy in place to support what they're doing. Do we have one in Tanzania? And if we don't have, I think all these achievements we have will not be sustainable. Because I know if another government comes, I think all the efforts done might not be sustained. But if we have, is it supported with other policies that we have? For instance, specialists are not recognized at district levels. And we had this problem with the NHIF, I think the new packages which are currently I think in the news, because if you have a specialist, for us who are in the private sector, at the district level, you have to ask for a special permission for him to be recognized to work at the district level. So the policies do not support this. So if you have, for instance, 82 the emergency department at district levels, I think our emergency physicians won't be attracted to work at this level. So I think we need to synchronize our policies with what we have in place. Thank you.
Good morning, everyone. And thank you, the keynote speakers, for really nice presentations. One is a comment for Professor Petra, but I wanted to make it for the whole congregation. One of the key things in our emergency medicine approach is that highly functioning team. And even my colleagues will agree, like when we work at the emergency department, our nurses and their skills kind of makes a whole lot of difference and more easy way of saving lives of our patients when we're working. But it's not a usual culture for most of the places to kind of, like most nurses would just like wait for orders, right? And we all agree, like at one point, I've been in the hospital and I would be asking for something as subjective thing, and the nurse will say, this is not written. Or the doctor didn't say, I need to do this. That's not how emergency medicine works. We work differently. And when I look at the presentation that Professor Petra did, I just wanted to call upon the nurses who are here, even the doctors, administrators, whoever is here, kind of advocate and make, we are one team. The functioning of the team depends on the skills of each member in our teams. Thank you so much for that. The other one, I wanted to comment on the growth that Erasto presented. Thank you so much. It's so humbling to see you there, up there, on the bigger table, and we are very hopeful. We feel proud, and also because we have big people here representing, we just want to really echo the issue of the environment that we work in. And the people matter. And emergency medicine is very expensive. So, because we have people here, I don't know if in any of the conversation we are going to talk about the costing and stuff somewhere in the breakout sessions, but we would want to say this, like saving one person's life is very expensive. Erasto projected a room from Brit's World, and that much for one bed there. For us, people would think it's luxury, but that is what it takes to just bring a person back in an orderly, good way. So people should understand from NHIF, from billing, from support, like we should be given priority when we ask for things. Thank you so much for the presentations.
Thank you to the keynote speakers for the eye-opening presentation. My question goes to Dr. Erasto. You said in the world of emergency medicine, one among the things that is going to change is having paramedics. So from our setting in the country, we have different levels of healthcares, let's say like the COs, AMO, MDs, then to the special people who are specialized. So from which point are you going to take the paramedics?
I think if we do, is there any hand I'm missing? Okay, then I think if we don't, I have a specific questions for Petra, and I'll just put it out there. My side job is being a coordinator of elective and exchange people in the department at the National Hospital. And one of the things that I usually, it's easy for me to do it with residents. We already have ongoing things. One of the things that I have with my nurses is they're always looking for nurses in Africa opportunities to improve themselves or to work themselves. From your experience, if you can give me what are the ways that nurses that work in emergency care in a setting like Tanzania what are the possible ways that I can advise them next time they come to my desk, that would be very helpful.
Okay. Hello? Yes. The first question, thank you very much for very nice questions. And the first one from Ali asked about how we can coordinate these emergency departments with the critical care services together, because they depend on each other. As he's worried that some of the facilities are having emergency departments without ICUs, and vice versa. Yeah, it is. I agree. It is a challenge, but we had to start from somewhere. And the good thing was all our referral hospitals, like regional referral hospital, national hospital, the zonal referral hospitals had ICUs and EMDs. Now, when we went to the district, at the district level, we had what we called the HDUs that were not very, very good, but they were still receiving patients. And the level of the emergency care that was being provided at the council level was what we called like casualty or acute care units. They could still receive patients with trauma right there and care for them. What we did was to upgrade that to a little bit of the standard that the patients can be received at and have the proper equipment. Basic ones, but they could serve a bigger role in saving lives. And what we did is to also improve the wards after the care of emergency medicine. So the ICUs, actually I did not mention this, but we have also out of the 82 emergency departments in the district hospitals, we have constructed 28 ICUs in those facilities. It is just a matter of capacity to build more, capacity to construct more, you know, the financial aspect of it. But we have tried to do that so that we can tackle that continuity of service issue. But we would wish to have very good care at the emergency department, but also a continuity of care at the ICU. That's the plan, and that's how the Ministry of Health has instructed us to do. That's one. Number two was about the policy issue. whether how do we sustain this gain now that the policy, the existing policy on emergency physicians, specialists, for example, are not recognized at the district level, and whether we have a policy for emergency care. We had a different name. We prepared what we called the emergency medicine operationalization and sustainability plan of emergency departments. It was like a plan, because we have one health policy, and these are the plans that are supporting the bigger policy. But from the presentation from Prof. Ben here, we have learned that we can upgrade that into emergency care policy. We are going to learn from you, and probably don't need to think again. We just, plug and play, plug and play. Yeah, we see how we can just adjust to our situation and go and move forward. We have a talk after this, so that we can better that one. So we have a short program. It's we call it a sustainability, the operationalization and sustainability plan for emergency departments and ICUs. It gives all these details on how the emergency department should be, how they should work, how and link with other services. And this is going to help us in the short run, but maybe in the future we have to develop a policy there. Of course, it's very important, even when we are developing now the emergency care services, the EMS, the emergency medical services. It will need a very bigger part in the policy to link this with other insurance services, the health insurance, so that all the people who are benefiting from this insurance can also get the ambulance care, referral services easily. So I understand this is a very big concern, and I think we should take up and see how we can adjust. And we advocate for specialists to go up to the level of to the district level, but our category of levels, we have primary health care and secondary. The primary ones involves also the district hospital, and in the past we would not think of having a specialist there because we did not have enough of them, even in what we call the referral hospitals. But going forward and understanding the need, I think this is what we can revise and talk to other institutions, including the health insurances, to make sure they understand and they accommodate specialists when they go to the district hospitals, etc. So this is something that we can work on. I will take up to the ministry. Another thing was having paramedics. Where are we going to get them, and which cadre or which part of the team, the healthcare workers, we are going to take? The clinic officers or MDs or nurses? We had 3 options, and we want to go with all of them because for now we do not have an option. Right now we are training the in-service healthcare workers to take care of our ambulances and take care of the referral services. We're still going to use the nurse and a doctor from the same facility that is transferring the patient for now. Later, we are going to use, maybe in 6 months, we have introduced what we call the community health worker program, the coordinated community health worker program. That they have like 6 roles, and emergency care, the first aid, referral, and basic emergency care is part of their module. So we are going to take them because we are going to employ or put them in contract around 1 maybe 150 in 3 years. And we have partners that are supporting right away this year, and they're going to be trained for 6 months to train preventive services, recognizing issues in the community, but some of them, because they are not going, all of them to be doing the same job, they'll be distributing. Other will be shifting just to transfer patients safely from the
doctors are the team. In terms of scope of practice, yes, there's a bit of variation in the scope of practice, but when it comes to saving lives, especially on emergency care, it's more or less a uniform kind of role, and everyone is a key member. As a doctor, you can't save a life alone. As a clinical officer, you can't save a life alone. As a nurse, you can't save a life alone. You need each other for you to actually save those lives. And building these team members and core of team members is key to any development of emergency care. And that's what we've done. So all our trainings that we do at facility level, even in my own emergency department, there's no training for nurses, training for doctors, training for clinical officers. They're all trained the same. They all practice the same within their scope of practice, but in the same space, so that at any given point the nurse knows what the doctor will be doing, and at any given point the doctor knows what the nurse should be doing. And this for us, especially in our emergency department, has been very helpful, because anytime there's a new doctor who comes in, it's the nurses who make sure that doctor doesn't kill patients, because the nurses know exactly. So when the doctor decides to do things off practice, the nurses will be the first ones to call out and say, no, in our department we don't do this way, this is the right way. So there's a lot of respect for the nursing team and all cadres at any given level. Just a comment, so that's a comment answer on that. There's a comment on the cost of emergency care. Emergency care is not afforded by the common person. It's the role of the government to provide emergency care. And it's something that we need to build, and we're building even in Kenya, that the government pays for emergency care. Proper emergency care cannot be afforded by, in fact, most of the insurances also refuse to pay for this. Because as you can see, the resources required to just save one life is a lot. Okay? And normally, by the time you're needing these resources is not the same time someone should be asking you, do you have money? So normally it's an unknown African man, a known African lady who has shown up, and they're busy dying, and you will use so many resources not knowing whether they'll be paid back or not. Okay? And that's why building cost structures that government pays for emergency care is key, and that's one of the next steps that we're working on at our level, to see that, make sure that the government is paying for emergency care. Thank you.
So just before I get to my question, I want to just say that in all this development, as we've heard, please think about the nursing as well. You cannot develop these systems without thinking about how you're going to develop nursing. People do it all the time, and then years later they say, oh, that was a mistake, because now I've got a big problem. So now, while you're doing all this amazing work, please make sure that you putting things in place to see how you're going to be developing nursing to be able to be this role, exactly what Ben is describing, you know, for the unit. And I'd also say that I think that we don't pay enough attention to putting retention strategies in place from the beginning, thinking about retention, because we get so caught up in how we're going to develop it, how we're going to train all these people, and absolutely, you know, so many of them end up leaving. So I think if from the beginning you start thinking about retention and how are you going to keep those people there, what will you be doing to encourage them to stay, it might just be worthwhile time thinking about for the future anyway. And then in terms of the nursing resources, for emergency nurses who are working clinically, there are quite a number of things, and I would just like to say that there's very strong emergency nurses in Muyambili, Dar es Salaam. A lot of work has been done, you know, around there, and there's great resources there in terms of nurses at that unit, and also, you know, in the university. I often serve as a link for people, so you're very welcome to link them up with me, and I will then put people in touch. But there's excellent nurses here in country that can serve to be role models there, assist the nurses, etc. I would also suggest that where possible you encourage them to do the basic emergency care course, if it's been offered around there, because that will really serve to highlight a lot of the skills that are necessary. Also to encourage the nurses in the unit and everyone here to become a member of the African Federation for Emergency Medicine. It doesn't cost you anything. And then become part of the nursing group, because we run free webinars every month. We have an induction booklet. We have all sorts of other resources that are all free, all for people to use. And what we find through those webinars, etc., is those nurses link up with each other and then help each other in other ways. So we're busy building this sort of community of emergency nurses out there. And then also just to say that a number of the nurses do leave and go to other countries to do formal education, be it in Kenya or South Africa or in Ghana, and the university here in Dar es Salaam does have opportunities for further studies as well. So there are actually quite a lot of resources here in country, but you're very welcome to reach out to me, and I will just put you in touch with these nurses, and then they can help you further. Thanks.
Thank you so much, everyone. In the interest of time, I think if we have any further questions for the people that are here, all our three keynotes, we'll take them during the break that is following the next few minutes up to, now it's 11:27, so we have a break up to 11:40. Again, thank you all the three keynotes for your lovely speeches and talks, and personally they've been very eye-opening, and in addition, I'm speaking for the rest too, possibly. Again, so we are heading out for a break, and these rooms will be partitioned to 3 breakout rooms. The main stage will be the Baobab, the middle room will be Mpingo, and far behind us there will be the Quiver room. So as we leave and we let the hotel staff partition this room, here where I'm standing, Baobab, in the middle, Mpingo, and where there are all those beautiful doors is the Quiver room. I hope that makes sense. Again, before we leave, I would like to take a couple of group pictures. I hope the pictures people are ready. First, I would like to welcome the guest of honors, plus Dr. Mabula, to join the keynotes here for a picture with you, get ready the organizing committee, and then we'll follow the speakers, and then the trainers. So again, organizing committee, Dr. Mabula, can you? Organizing committee will be the first, then the speakers, then the trainers, then the participants. So, organizing committee, can you also start moving? Yes, Dr. Said, Farida. You guys can be seated, and then people will line up behind you. Farida, Simbila. Okay. If the keynotes and the guest of honors can sit so that we can take the pictures. Yeah, you guys can sit so that people can line behind you and take the pictures. The three keynotes and the 3 speakers, you guys can sit so that it's easier people to come behind you. Unless your best position is standing, then, but it's easier if you sit so that everybody can just come behind. Rasto Ben. Okay, fine. So this is the organizing committee and the table. Great. So this is picture one. Following are the speakers. Speakers. Thank you. Can I have the speakers start moving, guys? Speakers. So if someone is the speaker here, they can still remain here. But speakers, can we come up? We have 10 minutes, guys. So, and it's supposed to go out there and get our coffee. Oh,
yeah, otherwise it looks like no one wants to be next to me.
Trainers for the pre-conference. Trainers for the pre-conference, and then next the participant. There are trainers for the pre-conference, BLS, AHA training, research training. Can we have the trainers up here? And then participants will be next. Trainers, are these all the trainers? Okay, good. Thank you. Participants. We can have a couple of people represent participants of the conference, guys. Thank you. A couple of you are photogenic and are looking really good today. Come and represent some of the participants. Yes, boss, you're photogenic, you can come. Yani mmegoma picha. Participants. Thank you. Can everybody come and get that nice pictures of all of us who are here? Thank you, Patrick. That was easy. Kama sio participant wa conference jamani. Tutatosha. Oh, 2 groups. Okay, fine. 3 groups? Okay. Photographer, where do we break so that the next group can come? Okay. Okay, so we're having another group. Okay. So these are enough. Can you see these? Or you want... kidogo alafu itakuja group ingine. No. Sikia, nusu wanapiga ya kwanza, nusu wanapiga ya pili, so msiondoke yote. There are going to be 2 groups so that everybody's picture can be seen. So can some of you come, and then we're going to have a second group, and then a third group. Msiondoke, yani mkua wengi hamjaonekana wote. So this is the first group here, guys. Come on. We are somehow in emergency system. We can do this very fast. Mwisho hapa. Kwa utaingia group unafuata na mimi. Tukae hapa pembeni. Okay. Group number 2 of participants.